right. All right. Welcome. We'll give people just a second to transition from the waiting room. This is our official first CE presentation for the summit, and this is the only CE presentation today. So as you are navigating through your CE Go dashboard, you will be able to see which disciplines are approved for CE credit, along with all of the other talks that are happening today. So I just wanted to be sure that everyone knows that this is the first CE session for today. And in order to get credit for the session, you do need to watch it live. There will be recordings of each of the sessions for the summit available to you in your dashboard. But for those that are looking to get the CE credit, you do have to attend the session live. Again, if there is an issue with technology and you need to hop off of a device and hop onto another device, no problem. We will make sure that you get your credit. So with that being said, we'll get right into it. I have the pleasure again of spending time with my colleagues here, and I'm going to introduce Dr. Shaun Riebl. Dr. Riebl provides trauma-informed nutrition therapy to individuals struggling with disordered eating and eating disorders. His passion for this population began with his master's thesis studying eating disorders in male cyclists, and he continued to explore eating behaviors during his doctoral work. Dr. Riebl has held assistant professorships at UNC Chapel Hill and the University of Mississippi, as well as research positions with Duke University. With over 15 years of clinical experience, he promotes freedom, flexibility, and nourishment with food while providing compassionate, evidence-based treatment for all people. Dr. Shaun Riebl, our Chief Nutrition Officer at Within Health, and again, Dr. Wendy Oliver-Pyatt, our co-founder of Within Health. Wendy's a leading expert on treating eating disorders with more than 25 years of clinical experience. She has developed 5 distinctive treatment programs, all grounded on a strong biopsychosocial foundation and incorporating intensive psychotherapy with behavioral foundations and high medical standards. Wendy has developed a unique treatment approach that delves into underlying issues that place a person at risk for mental health conditions and eating disorders and lead to healing, health, and inner peace. So without further ado, I will turn it over to Dr. Riebl and Dr. Pyatt.
So
Thank you, Jamie. Thanks for all your hard work in this. The summit is your baby. We're so grateful that we have this summit. And all the welcoming messages in the chat were just so lovely to see. Thank you guys.
And thank you. And you guys, please utilize your chat. Please let us know where you're checking in from. Let us know what you think. Please place any questions there. There will be clinical predicaments that will be discussed throughout this presentation. And so our presenters have kindly asked that you utilize the question box so that they can see your questions and that we can make sure that any concerns or questions you have, we can get to them. Thank you.
Thanks, Jamie.
Thanks so much, Jamie.
We're off and running, Shaun.
We are. Here we go.
So we wanted to just start by kind of putting the broader, view that just reminding ourselves that we're living in this era, of these GLP-1 type medications. And it's a new era in the sense that it's a new medication that hasn't been readily available. But at the same time, it's a continuation, right, of the saga of the journey of intentional weight loss efforts, whether it's through dieting or other drugs that have been available. And these intentional weight loss goes back so far, and the pursuit of thinness, the pursuit of biological changes to our body that deny our biological reality, that's been a part of our society. And now with the fact that we have social media also happening at the same time that these medications are so readily available. Our co-founder, Abby, just told me that apparently Walmart's going to put these medications. So before we even talk about the medication, these medications, we need to set the stage and realize we're living in this era where there's these very powerful compounds, readily available, and the social contagion that's placing these medications in the forefront of our mind. A social contagion, the literal definition is the spread of emotions and behaviors through groups of people often influencing individuals to act or feel similarly to those around them without their conscious awareness. This phenomenon can explain rapid social change, the spread of fads and trends, and even increase aggressive and self-harming behavior. So we really are living during this era of GLP-1s, and the point of our talk today is to really talk about these holistically and not to label them good, bad, or otherwise, but to more deal with the reality that they're present and hopefully shed some light on how they can be thought about and what Shaun and I, what we've experienced in our own lived experience as clinicians in this era. I think recognizing, though, that these medications do make a lot of money for folks, and then all the continued medications that are the byproduct of the impact of these medications, which essentially cause starvation. So this slide just shows the nutrition support for your journey. So there's a lot of money to be made in us hating and not accepting our bodies as is.
Love that.
Yeah. So we wanted to really talk about the theory of what GLP-1s are all about, what the beliefs are about there, what the medical community tends to convey, and then the reality. And the overarching concept here is it goes back to weight stigma in essence, because our society does have this generalized belief that weight loss, equals health and happiness. And that's one of the things we're really going to talk about, whether or not that's actually true, and what are the potential medical and psychological harms of these medications, because we really will talk about informed consent as well. So we think about, there's theoretical guidelines also as to how these medications are supposed to be used. Like theoretically, a doctor is supposed to prescribe these medications. You're supposed to be followed carefully by the doctor who's monitoring the side effects. The doctor is supposed to be paying attention to dose increments and thinking about how the medication's affecting you. Like that's theoretically how these medications came to be. However, we'll talk about the fact there's no black box warning around eating disorders. But and then patients have expectations that, okay, these medications are going to improve my health. I'm going to have better metabolic functioning, blood pressure, mobility, blood sugar, cholesterol. These things are all going to change as a result of these medications. And one of the things that I think is super important to talk about when we're talking about any kind of intentional weight loss is informed consent. And I was telling Shaun that going back to the early 2000s, 2002, 2003, 2004, some of my very first talks I ever gave in the field of eating disorders, I had a talk about informed consent, because even a diet itself, we think of dieting in this very casual way. Oh, I'm going on a diet. I'm going on the South Beach diet. I remember Sugar Busters. I remember, I remember, oh my gosh, the TWA Stewart diet. I'm traumatized by that one. But we think of diets very casually, but dieting is in and of itself a medical intervention. And certainly these medications are medical interventions. And any medical intervention, doctors are trained, should have informed consent. So from a simple diet to a GLP-1, all of these are medical interventions that should have informed consent. What is it and why it matters? Informed consent is a process of providing a patient or a research participant all relevant information about a proposed intervention or study so they can make a voluntary and educated decision. And informed consent involves disclosure of the risks, benefits, and alternatives. In order to carry out informed consent, I cannot provide informed consent to Shaun unless I know that Shaun, as an individual, understands this information that I'm conveying. So there is this sort of element of competence that is a part of informed consent. Voluntariness is the person is freely, without coercion going forward. Competence, so it's not just the comprehension, it's the person is competent to make the decision, and then the consent is actually given. It's an explicit agreement to proceed. And by the way, consent actually should happen on an ongoing basis. So just because somebody gives consent in the first, before they start these medications, as the person's going on and different effects are happening, the doctor needs to be continuously looking at and evaluating whether the consent still continues. Are they still informed? Do they still comprehend what's happening? And then are they still giving consent to continue on with this? And I would argue that not only the expectations of these medications is actually sometimes unrealistic, but also that I think we're failing miserably as a medical community in providing informed consent for these medications. And yes, I have a problem with that.
Yes. And so when we're talking about these medications, we wanted to make sure that we were all on the same page from the same starting point. So when we're talking about GLPs, GLP stands for glucagon-like peptide 1. Okay, so it's a hormone that our bodies naturally produce in the gut after we eat. Okay, it's one of the hormones, one of many hormones actually. Okay, so these medications, when we're talking about them, there are synthetic versions of that same hormone. Something that's interesting is that these GLP-1s, they've been around since the 70s. Back in the 70s, researchers were studying them as a possible treatment for duodenal ulcers. And I know that's a bigger word, small intestine. Think about your intestines, so ulcers in your intestines. They've been on the market for almost 20 years now, so they're really not as new as they might seem. The thing that is new is that what makes them feel new is that more recent clinical trials, especially over the past decade or so, shows benefits, like potential benefits for blood glucose control, so type 2 diabetes management, but also there's some inklings of cardiovascular benefits or even kidney health. Okay. These meds, when we're talking about them, they come in two main forms, which are injection, which is the majority of them, or a pill. Okay. And they enhance what the gut brain axis already does after we eat. So in other words, what that means is it fine tunes how the body and brain communicate. Okay. So that's the main thing. It's synthetically doing that. So what they do is they regulate blood sugar, they slow down gastric emptying, they influence all hormones, not all, but many gut brain hormones, which actually affects the hypothalamus in the brain, which we'll see shortly. And that is going to play a role in how we feel with our hunger and fullness, but also emotionally. Okay. When we're thinking of these also, they reduce appetite. So overall, these meds, they help align like what the gut, the pancreas, and brain, like they help all align those and can control blood sugar to some extent, reduces appetite, and also can potentially help with even food noise. And we see that on this slide. Okay, so when we talk about the different types, we wanted to make sure that everybody understood all the different names, because I don't know about you, Wendy, but for me, with my social media feed, I get many advertisements for different medications, whether it's for weight loss or other types of conditions. But the thing that we wanted to highlight here is that semaglutide, that's Ozempic or Wegovy. That's basically Ozempic was used for type 2 diabetes, but then also became for weight loss. So that's with Wegovy and whatnot, but you'll hear more about Ozempic being prescribed. You'll hear about trizepatide as well, and that's also known as Mounjaro or Zepbound. Okay, there's another one you probably heard of Trulicity. There's an oral form, and that's Rybelsus, excuse me, Rybelsus. And that's the one in the list here. And then there's one that I just added recently because this is a triple agonist. And what that means is that instead of working on just GLP, it works on 3 different peptides. So that's one that's in clinical trials as well. It's called retatrutide. So those are interesting and things for you guys to know when we're talking about these meds, especially when you hear of your patients or family members or even yourself, what these meds specifically are. Okay. Now, what are we seeing with like long-term outcomes with some of these? So with this one study that we wanted to mention here, researchers, they were looking at the rates and factors of discontinuation and then subsequent like restarting the GLP-1s. And you could see we have it outlined on the slide of, okay, type 1, people with type 1, people without type 1. So researchers conducted a cohort study. And so I just don't want to throw around research terms without people understanding. A cohort study is basically an observational study that tracks a group of people who is the cohort, and they have shared characteristics and they see how a certain exposure affects a particular outcome. Okay. If I just lost you, don't worry about it. It's a cohort study. Okay. We'll just keep it at that. Point is that it was over 125,000 people. Okay. Most of the people that were in the study, they were found to discontinue the GLP-1 med specifically. Okay. What we see, so conclusion wise, the rates of discontinuation were significantly higher for those without type 2 diabetes. Okay. So what happens though when those meds are stopped? Well, this study looked at the lead up for 2 years and then 2 years afterwards, but we don't know further than that. But what we do see, yes, some of those side effects that we'll hit on in a little while, those decrease. But what we find is that weight that people so were looking for was regained. But in addition, those other benefit, like quote unquote benefits, the cardiovascular, the blood sugar regulation, all those things came back to baseline. So those are the
Yeah.
things we have to consider with these meds.
The
Anything?
other thing I think that's interesting about these meds that I think weight stigma is also woven into them is that the actual dosage guidelines for folks that are taking Wegovy, which is the weight loss version of, it's the same compound. These are the same exact compounds with the semaglutide, but the dosage recommendation for weight loss is higher than the dosage recommendation for diabetes. So it's sort of like, oh, for the people in the larger body, we're just gonna like kind of hit you harder. And then you can see they tend to go almost 2/3 go off, right? And then they just gain the weight back. So just wanted to throw that in the mix.
Great point. Great point.
So one of the things that is really concerning to me is that yes, there is a GLP, there are black box warnings for GLPs. There is a black box warning due to the risk of thyroid C-cell tumors and a question about the drugs causing medullary thyroid carcinoma in humans. So that doesn't get too much discussion, but I think it's actually something very real. It's a black box warning. However, I find it so disturbing and so concerning that there is a lack of recommendation for screening and monitoring for the emergence of side effects with these medications. And these medications, and we're going to talk a lot about this, about the impact on hunger, but these medications literally actually induce eating disorder symptoms, anorexia nervosa symptoms. These medications induce those symptoms, and there is no black box warning for the emergence of eating disorders. And it's absolutely astonishing to me. And not only that, so many of these different medical societies, including the American Academy of Pediatrics, came in with these recommendations for using these medications in certain situations, with there being so little research around the long-term effect and with there being no guidelines for screening and monitoring for the emergence of eating disorder. So it's really astonishing. And I do have to say, I do believe this is weight stigma, at play, that this actually happened. That is weight stigma in effect. So just looking at some of the research, can GLPs cause eating disorder? The research is actually limited. However, it's very obvious to any of us with lived experience, right, that we certainly can see how GLP-1s can cause and exacerbate eating disorders. So in a person with a prior history, I've certainly treated patients with a prior history of eating disorder who went into stable recovery, who got put on a medication for diabetes, and then had an exacerbation of like a medically induced eating disorder. So we know the research may be a little bit limited, but we now live in an era, thank goodness, where lived experience actually matters, and we really need to pay attention to that. There is this research out now about GLP-1s, quote, helping binge eating disorder. Firstly, we will come back to that. Shaun and I have a lot to say about that. But long-term studies have not really been established. GLP-1s can actually present barriers to eating disorder treatment. So it can be harder for us to actually, for example, encourage people to complete meals when they are having their hunger signal essentially shut down. So it can really be a barrier to good treatment. We do admit people to our program. We do not close the door just because they're taking the medication. We want to work with people with where they're at. However, there are different scenarios that come up. Certainly, we have people with eating disorders and type 2 diabetes in our program. And that patient we may work with differently than a person who has an eating disorder and is on these medications. We might take a firmer position about really helping them to get off if we really think that that is actually interfering with treatment. And Shaun, you may have a little bit to share about that.
No, absolutely. And so even thinking of that, Wendy, what you mentioned, one of the main things that we do as a team is look at the why and also look at the how. And what I mean by that is we're not interrogating people. We're trying to understand what got them to us today. Who is the person that we're talking to today? Where did this medication come from? And what was the rationale? Was there informed consent? Because what we found actually in some clients' cases that we have when someone is perhaps struggling with it, and I'm hesitating because atypical anorexia, when we think of it, it's really anorexia, right? Like that, it's anorexia. But when someone has a BMI that's in a certain range, they can all of a sudden get access to this drug when they have a full-blown raging anorexia symptomology. And it's unbelievable. And that's something that those are the conversations that we need to have with our clients. So just to be clear for everyone, like what Wendy said, there are indications where these medications can be used and can be used safely. And there are times where they aren't safe as well. And that's what our role is as clinicians, is to explore that with clients.
Absolutely.
So we're gonna go into a little more of the science behind these meds. Don't worry, don't buckle your seatbelt. Like it's not going to be that hard, I promise. The point is we want you to understand. We want you to know, okay, what's the mechanism? If my client comes to me, even if I know that my aunt is on this medication, what do I need to know if it's one of my loved ones, right? So the GLP-1s, they have several mechanisms in play. And what you can see here is this is a graphic representation that we have there. You could see, okay, it's hitting on the pancreas first and foremost. What is it doing there? It's increasing the production of insulin, decreasing the production of glucagon. And this is specifically for GLP-1, for glucagon-like peptide, okay? So if you don't know what glucagon is also a hormone. It helps bring glucose out of storage, okay, and into the bloodstream, just so everyone understands that. If you go up top, you can see in the stomach, what happens? Well, we have slowed motility, so slowed gastric emptying. So when that happens, digestion slows down, okay? So that's something to know there. When that can be problematic for many reasons, like Wendy mentioned about someone finishing a meal and whatnot. So hold on to that one. Also, we can't ignore the central nervous system effects. So on the brain, there's this connection between the gut and brain, specifically in the appetite centers of the hypothalamus. So what happens is it reduces our food foraging. So we don't have an appetite or hunger, and therefore our meal, intake will decrease as well. Okay. But you can see that again, it works on that gut brain axis, but then there are these secondary effects as well. And that's what you can see in this slide as well. So we didn't want to go, ignore these other aspects too. You could see again, we have the pancreas, gastrointestinal tract, that's the GIT in the top left, and the brain. But you also see the secondary effects as well with the heart, the kidney, and how it also affects muscle and fat tissue as well as the liver there. And so this one is a really great one of what we just went over, but in a visual concept. This is something that's a really great visual. Wendy, anything you wanted to add to this one?
Yeah, I mean, I think one of the things we were just talking about is that these medications really induce symptoms of what an eating disorder presents. So if you look at the brain, right, decrease appetite, increase satiety, so getting full sooner. And then a big one there is the decreased gastric emptying and the decreased of the GI motility. These things are very, very significant as far as eating disorder symptoms go, because we're literally taking a compound that's actually bringing about the metabolic and physiological aspects of what starvation from anorexia nervosa actually induces. And that is pretty scary if you ask me. I mean, there's so many other things here that really does matter, but we'll keep talking about that. But one thing I also want to just point out, since we're on the slide here, is the muscle breakdown and the sarcopenia. That is something that has been really missed in modern medicine, the actual impact on sarcopenia and breaking down muscle. And something that is also not on this slide that is really relevant to especially to kids, but the weight loss and the lack of nourishment and the impact on bone development and osteopenia and osteoporosis. So just calling out those ideas of like we're inducing eating disorder symptoms. We've sort of, I think, forgotten about sarcopenia, and I think we're kind of forgetting a little bit about osteopenia and osteoporosis, in addition to everything else.
Exactly. And those are the end result from creating that malnourished state.
Yeah.
Yep. Cool. So something else we wanted to make sure everybody understood was the difference between some of the drugs that are out there. So I mentioned the triple receptor agonist, the dual receptor agonist. So we wanted to take a minute to camp out on this. So when we're talking about the GLP-1s or the GLP-1 receptor agonists or RAs, that's specifically semaglutide. It's liraglutide, dulaglutide as well. So different meds, okay, but they fall under that one receptor. They're just working on GLP. When we look at tirzepatide, tirzepatide is a dual receptor agonist. So what that means is that it's working on two different peptides. Specifically, it works on GLP and GIP. Okay, so GIP is specifically gastric inhibitory polypeptide. Both of these peptides stimulate a decrease in blood sugar levels, okay? And they're both called incretins. I'm not going to go into the details of incretins. There's something that's called the incretin effect that really helps us understand some more about diabetes and blood sugar, but just know that they have a main effect with specifically blood glucose levels. Okay, both of these meds stimulate the beta cells in the pancreas to release more insulin, which has that direct effect on blood glucose levels. The difference is that the GLP-1s inhibit secretion of glucagon, while GIP does not. Okay, so the main thing is, though, what you can see here, some of the literature, and I have studies that if you all are really interested in, I'm happy to share that after. You could look at the Surmount trials and whatnot, but what they show is that there's greater blood sugar reductions with the tirzepatide and also some quote unquote better weight loss results, if you think of that. Okay, the side effect profiles, though, are still under study, but they do contain similar side effects with them. Okay, but the main thing to know, both of these GLP and GIP, both tirzepatide and GLP-1 receptor agonists, they contribute to blood glucose regulation as well as insulin secretion. GLPs play a more prominent role with appetite, though. They have more of that central nervous system control there. Okay. Oops. Where's that? There we go. Okay.
Just a little bit about compounded medications that we wanted to bring into the discussion that we see a lot. I mean, you talked about your social media. I think because of the work in our space, we get a lot of information. So this is really out here, the use of compounded medications. These are custom formulations that are made by pharmacies. They are not the FDA regulated forms of these medication. There is a lower cost to these, and there is no FDA approval and no monitoring necessarily of doses. So there does leave the possibility of dosing errors. There's legal issues related to these medications, but they are actually out there and being used widely. And again, a lot of times it kind of ties into accessibility. And I think for the most part, the medical community in general has done overall a very poor job of laying out the risks and benefits of these medications. Like perhaps using custom formulations out of lower doses might serve patients by having fewer side effects, but on the flip side, you really aren't sure what you are actually getting because there is definitely room for dosage error in the use of these medications. And so we think it's important to just keep that in the back of our minds as we're thinking about these medications. So again, we were talking a little bit about microdosing, which is also a potential avenue of treatment. And I think that there may be something about this for certain patients who are insisting on being on these drugs, that there may be reducing harm by being on lower doses. In any case, though, a risk-benefit analysis needs to be done and an informed consent needs to happen. There is at this point a lack of standardized protocols around this, but then again, the protocols that are actually in effect which, as mentioned, for those with that are using Wegovy, which is the supposed treatment for O or for weight loss, does have a higher dosage threshold that patients are expected to take. And again, there are no long-term outcome studies that we really can be sure of how it's going to go for people who are microdosing.
Cool.
So Shaun went over all those different, the organ systems and how these medications hit these different organ systems and different tissue groups, which are organ systems. So what is the effect on our actual body? So a very common side effect is nausea and vomiting, diarrhea, constipation. So GI issues are really, really strong, really prominent, I think, for these patients. Certainly fatigue is a very big one. Just being weak and fatigue, that's something we've seen a lot of. Oddly or interestingly enough, I've had I've had a patient of an older woman that had a history of congestive heart failure that was put on the medication supposedly to improve her heart functioning. And the lack of nourishment, because it literally induced an eating disorder in her, which she had a prior history of. The weakness and the lack of nourishment actually exacerbated her congestive heart failure. She became very fatigued, very weak. Blood pressure was lower, heart rate was lower. So even though she was actually put on the medication at the encouragement of our cardiologist, who in the cardiologist's brain was like, these medications help with like cardiac functioning. Well, not if there's an endpoint to that once the person's like massively malnourished. They can actually cause overdose and death and organ damage, cancers. And we'll talk a little bit more about the exacerbation of mental health issues. And we have a section on that, so I'll wait to get to that. But certainly also we know about the black box label for the development of tumors. And there's others as well, but these are the most common.
One thing, Wendy, I just want to add. So we talk about the GI effects. Anecdotally, literature-wise, if you look at research, it says, oh, okay, diarrhea hit, X amount of people with the clinical studies. Anecdotally, constipation has been something that I've seen with clients that comes and persists. That's not something that goes away. When you think of it, it makes sense because of the motility issues that are pervasive. But I just want to highlight that it's something that we constantly see. So if you yourself are on this med and you're experiencing that, no, that could be potentially the reason. And sometimes food gets thought of it as like, oh, you'll just be told by your doctor, well, just eat more fiber. Like that's what you need to do. And it's actually, well, wait, let's kind of go to the more upstream effects of
Yeah, I mean, and there are cases of significant GI issues causing bowel obstruction and death. There are, that has happened. And I don't know the incidence of that, by the way, but I'm interested in that. But there absolutely has been deaths due to bowel obstruction.
For sure. Excellent.
So also another thing that we don't think happens very frequently as standard, and Shaun's going to talk more about this, monitoring and nutritional pieces of this, but we don't believe that adequate medical monitoring is happening. We see blood glucose levels changing, and they need to be monitored daily or as needed. Hemoglobin A1C, kidney function, baseline and periodically. Electrolytes are certainly an issue. Shaun's going to talk a lot about that, the electrolyte issues. There's micronutrient deficiencies also. Shaun's going to get into that. There can be LFT issues. There can be pancreatitis. So amylase and lipase are very important, especially if there's abdominal pain. We know about the thyroid medullary cancer, so monitoring thyroid function. And also gallbladder is another issue because rapid weight loss can actually cause major gallbladder issues. So that's just something that we know in general. So in that case, even people needing a cholecystectomy in the case of rapid weight loss and weight cycling can actually cause significant gallbladder function. And then weight and vitals needs to happen because we do have this idea, again, just because of weight stigma, weight loss equals health. And there is absolutely cause for alarm on the whole entire body and all the organ systems when there's rapid weight loss. In fact, in medical management of eating disorders, we have this concept of the sinking ship. So we know if somebody comes to our program and they have had really rapid weight loss, even if they aren't supposedly low BMI or whatever, but if they are a quote atypical anorexia patient and they've lost weight, I don't care what their BMI, they've lost weight fast, that increases the potential for cardiac effects and cardiac failure. So doctors need to pay attention to what is actually happening with the weights and looking at what their heart rates are, and are they checking them for orthostatic hypotension, which is not routinely done.
Yeah. So we wanted to pose a clinical reflection. Okay, we've been talking about all these meds and some of the influences and effects that this class of medication has. I invite you to consider this question. What happens when hunger which is already confusing, perhaps even a scary signal for many people, especially those with eating disorders, gets turned off pharmacologically? What I think of with that is just how much this can reinforce the belief that nourishment, that actually feeding ourselves adequately, is optional or even unsafe. Okay, so that's something to consider there. We're going to move into some of the nutritional risks here. Now, with appetite and intake reduced, clients or patients, they may unintentionally or intentionally underconsume key nutrients. This is especially concerning with food choices when they're already limited due to food fears, rigid rules, or even other GI side effects that might be happening because of eating disorder symptoms, okay, or even rigid rules, etc. So when we have, like, say someone has nausea and early satiety, and that leads to selective and restrictive eating, then that further leads to complete food group avoidance. That's problematic. That's a risk. Okay. Another thing here that you can see at the bottom, which is very interesting, that goes overlooked some of the time, I'll say most of the time, I'll be dehydration, blunted hunger, and thirst. So in the brain, GLP-1 plays a direct role in modulating thirst perception, as well as, so if it's messing with our thirst perception in our brains, we're not gonna drink water. So that's thought to directly inhibit what's called antidiuretic hormone, okay, or vasopressin. Okay, so this is a peptide, it's produced in the brain, plays a key role in our water regulation. Okay, so the main thing is that we can't ignore that, because when you think of dehydration, there's some really important signs and symptoms we can't ignore, especially when we're taking these meds. So when someone has a co-occurring eating disorder, we're going to have those reduced thirst cues. And then we put that onto food or fluid restriction and sets the stage for dehydration. So mild dehydration might present subtly. It's sometimes mistaken as fatigue or mood changes, which is true. That can be definitely a symptom of it. But we're also going to see dry mouth, fatigue, headaches, and even dark urine. Okay. Many patients typically won't report these symptoms unless they're asked. So we have to ask about thirst, urine color, dizziness. And those are things that we include on our nutrition reassessments and assessments to make sure that we understand what's going on for our client. On the right hand of the screen, you can see severe dehydration. This is more dangerous. This is a medical emergency. This can show up with what Wendy was mentioning, like low blood pressure, so hypotension, rapid heart rate, so tachycardia, as well as confusion. We want to make sure that we are especially careful with those who have a history of purging, laxative use, or even report nausea from the GLP-1s, okay? Regardless of someone's history, though, we need to stay alert for these signs of dehydration, even without overt vomiting or diarrhea, because the metabolic effects of these medications, okay? So electrolytes, when we have imbalances, it could be deadly. Okay, they typically go undetected until serious complications arise. So even with people that are struggling with eating disorders, they have a risk of electrolyte disturbances. Throw on a GLP-1 and the GI symptoms, that's even amplified there. So you have electrolytes like potassium, sodium, magnesium, and calcium. Those are all important in nerve and muscle function, including the heart. Okay. So even minor imbalances can really cause symptoms, fatigue, dizziness, but even more severe symptoms will have cardiac arrhythmias, seizures, even sudden death. So we want to make sure, like Wendy mentioned before, that we're monitoring these values regularly, specifically if someone is purging or if they are reporting these medication side effects. All right. When we're diving into a couple of these specific ones, you can see low potassium and low sodium here. Okay, so these are the most common and most dangerous imbalances that we see. Hypokalemia, which is low potassium, it's caused by diuretics or vomiting. It can result in muscle cramps, fatigue, heart rhythm issues, things like that. If you see a patient with constipation or fatigue, don't overlook the possibility of potassium being off. Okay, it can cause low potassium because potassium is essential for proper muscle function. Okay, including the muscles that propel food through the digestive system. So when potassium levels are too low, the muscles in the digestive system, they weaken, and that will slow down digestion. Throw on the med, you're creating an opportunity for disaster here. Now,
And also
oh yeah.
the potassium, sorry, just really
Mhm.
quickly mentioning too that the hypokalemia also affects the heart, right?
Exactly.
So,
That's
yeah.
yep. And so that's the other thing too, when we're thinking of those serious complications, something happens with the heart, that's not fun. No
Mm.
fun, right? So low sodium, that can result from excessive water intake as well, but with patients trying to feel full, as many people probably know, but it can also be triggered by specifically vomiting and diarrhea. All right. So you could see some of the symptoms there as well. So
Shaun, I was just thinking of one other thing as you're going over this, because these are such dangerous things that you're pointing out to all of us and to the audience today. And I'm thinking to myself, how many patients before they get put on these medications, how many of them are ever told about the risk of hypokalemia and hyponatremia or constipation? It's just,
exactly.
I just had that thought as you were talking. So
Well,
anyway,
and it goes back to the informed consent, what you
yeah.
mentioned before, right? Like, I think knowledge is power for us, right? Like, if we know what's going to happen, then we can make the most informed choice. If we know about this, then that can help us be smart with how we make the next steps, what next steps we do take. Okay. So moving on, we have low magnesium and low calcium as well. These play critical roles, especially in nerve and muscle function. Whoops, excuse me there. So low magnesium is under-recognized, but it can specifically exacerbate cardiac and neurologic issues, especially in malnourished patients. Okay, so that's one thing we need to be considerate about, especially with the co-occurring eating disorders. It can present as anxiety, tremors, muscle spasms, symptoms that are sometimes thought of as like psychological issues in eating disorders, but it might actually be an electrolyte imbalance. Hypocalcemia, you'll see as like numbness or tingling or twitching. I'll never forget talking to a client in a session, and the bottom of her lip on the right was shivering, like spazzing out, and I was just like, oh my goodness, like what's going on here? Turns out hypocalcemia was to boot for that one. So these are subtle and critical. These are subtle but critical to catch in the eating disorder population. Okay. So both of these deficiencies are common in malnourished patients or those on restrictive diets. So if someone's taking a GLP-1, they have that reduced appetite, they're going to be restricting their food intake. Additionally, you throw the slow gastric emptying on that. Again, it's another recipe for disaster. Okay. So moving on to malnutrition, one of the main concerns with these medications that we cannot ignore. So even if a patient like appears stable in weight, these functional symptoms can indicate an underlying malnutrition. So we cannot always just rely on the scale. You have to look beyond the scale to understand what's going on for your clients. Okay. So what I wanted to show you guys is the six diagnostic characteristics for malnutrition. And so you could see you have inadequate energy intake, which is a decrease in food or nutrient intake compared to estimated intake over time. Okay. So basically what we might be looking at is like looking at a 24-hour recall, calorie counts, etc. We're looking through all that. Then you could see weight loss. and loss of muscle mass, loss of sub-Q fat, and then edema or fluid accumulation, as well as functional status, right? So you can see that the top two, number 1 and 2, those two criteria are ones that are super important for the diagnosis, okay? It's based on the degree that you see, like the moderate and severe up there are based on the degree of inadequate intake and the weight, muscle, fat loss, and the duration of that, okay? So I wanted to show you guys specific charts that we use at Within that can help you understand what's going on for someone specifically with acute as well as chronic malnutrition. And you can see the weight loss over time, and that will help you determine, okay, where is my patient lying? Like, where's my client lying within these parameters, and how severe is this? And also can help you if you're taking this med of understanding what's going on for your body and how you might be at risk for the complications of malnutrition. So like I mentioned just before with some of that weight loss and the energy intake, we do want to use specific tools. So a nutrition assessment must be individualized and comprehensive. We're going to look at labs, weight, food intake, food history, diet history, as well as reported symptoms that can help us identify early risk, right? So additionally, we want to look at food rules. So we're going to look at eating attitudes and norms. Remember, as a team, we want to consult with each other. Other people are going to have information. In the past session, Wendy was talking about the importance of the care partners and the nurses. Those can sometimes be the people that are helping us, dietitians, get the most information that we need. Clients are going to tell us everything. We're the food police. Like, we're the people they don't want to talk to. Like, so we need to talk to the whole team, not to be detectives in that way or to be weird about it, to go behind the client's back. No, we want to provide comprehensive, compassionate, informed care for our clients. And so we want to be sure that we're having that interdisciplinary communication. Okay.
I think also when you guys are communicating with the care partners about what they're eating, even though the patients might feel like, wow, they're like, that's kind of nosy of them, but they also feel loved and cared for, and that you really are paying attention. So there's like, and that's the way you and the team always goes about it. It is a loving act, and it is a very attentive thing that needs to happen for people on these medications. Like, there needs to be somebody paying attention to how, whether they're in Within, or, we're still working with them and they're on the medications, or they're like, we need to be nosy and ask people, like you're saying, be detailed and be holistic and show that we care if they're not eating enough, not like applauding that.
Lovingly intrusive, a
Yes.
wise woman once said to me.
Lovingly intrusive. Yep.
Right? So that's the thing. We need to be up all in their business because we care. And
Yep.
we're gonna be with them through this. Nice. So micronutrient deficiencies, right? So we need to be looking for these, especially with someone that's taking one of these medications in addition to the eating disorder. Okay, we need a nuanced and comprehensive approach, combining our clinical judgment with specifically like targeted screening that can help us see the risks, malabsorption, the delayed gastric emptying, the GI losses. We need to look at all that all together to understand what's going on for this client. So here's how we can assess them effectively. Specifically, we want to look at dietary intake. You can ask, okay, what foods are being consumed regularly? What food groups are they eliminating, if any? So these can be helpful questions for you guys to ask your clients or even yourself of, okay, what's going on right now, and where do some of my risks lie?
I'm
So
so glad that you talk about these micronutrient deficiencies, because they're really very significant and really not well looked at. And we've really seen some major problems with these, like iron deficiency, anemia, and things like that. So just so grateful that you're presenting this, Shaun, to the
Well, and
group.
Wendy, I appreciate you mentioning that because as a dietitian and from my other nutritionally informed friends out there, right? Like, you might be like, "Oh my goodness, why are we going over the foundational principles?" Y'all, like what Wendy mentioned before, these drugs, what we're facing, it's still a diet. it's still weight loss. There isn't something complicated happening. Yes, there are mechanisms involved, but it comes down to the basics of, okay, malnutrition, electrolyte imbalances, micronutrient deficiencies, because our clients are going to come to us, oh man, I'm having this GI upset. My nails are super brittle. My hair is thinning. Okay, like we don't like it gets we get lost. We get lost. We have to go back to the simplicity of, hey, okay, what's the eating disorder symptoms look like? How is that happening? I'm not saying it's always the eating disorder. So for those people out there that are like, hey, wait a sec, I was told it's the eating disorder and it wasn't. I absolutely believe you, and we're going to be compassionate on that. My point is we need to be inclusive and comprehensive of what we're looking at and not rule out anything and just kind of put something on the shelf when in reality it's smacking us in the face. All right. So to move on here, you guys can see the signs and symptoms for specific micronutrients and specific lab tests. I'm not going to go into them very much here at all. The main point is that this is a great resource for you for a quick reference. You could have it for yourself. You could save it on your phone or whatnot to see, okay, if one of my loved ones or myself or someone I'm caring for is experiencing these signs or symptoms, hey, connect with a provider about it. You might need to get some lab results done to see what's really contributing to what's happening for you, especially if there are disordered eating patterns going on or the GLP-1 meds as well, you know. So when we think about everything that we just covered with the nutrition, please consider the effects of the GLP-1 receptor agonists. They can reduce overall energy intake and micronutrient intake, especially if a client or patient is experiencing nausea, early satiety, or even like vomiting as well. Okay, this can lead to malnutrition. Therefore, we need to tailor our assessments to the symptoms and patterns that we're seeing in our clients, specifically not just using weight, but looking at labs and clinical signs to help us identify risk and identify that risk early. Okay, we want to make sure that we can make corrections sooner versus later. Since the GLP-1s might exacerbate these nutritional risks, we need to be on top of it. We can't allow these things just to go by and, like I mentioned, just put it on a shelf and chalk it up to something else that's going on. We have to get to the upstream factors and go from there. Cool.
So the other thing that, of course, in our society, we hear all about the O word, all about that, and you know how terrible that is, and how much it's harming, you know, society and people, and it's the worst thing ever. Whereas this 20 years later from me giving my first talks on eating disorders and talking about weight cycling is still hardly ever mentioned. And when we're doing informed consent with these medications, we need to include weight cycling because almost, what was it, about 63% of people who take Wegovy for weight loss actually go off of these medications. And once they go off the medication, for the most part, they regain the weight. And when the weight goes up and down over time, remember that we're having effect on our whole system. We're actually, when we're losing weight, we're losing muscle as well. So when you lose weight, you're losing not just body fat, you're also losing muscle. And then when you start eating again, your metabolism is now slowed down. You have less muscle that also burns less fuel. So you're more likely to gain more weight back once you actually start eating. So that's why weight doesn't just, you know, once you go off the medications, you can expect down, up, down, up, down, up as you diet or go back on the medication. But over time, weight cycling tends to go upward and people gain weight. And then the entire body and multiple organ systems are affected. So the damage to the heart and the cardiovascular system, there is increased inflammation. I've talked a lot. I always try to talk about bone mass, osteopenia. We talked about gallstones and the need for, you know, these emergency gallbladder surgeries we see a lot in the rapid weight loss. There are some research into the potential effect on DNA damage and cell changes in breast tissue. Certainly physical weakness, and also when you are nutritionally deprived, it can also affect your tryptophan levels, and that affects serotonin function. And ironically, lower tryptophan levels actually increase impulsivity and depression. So you may be doing something to your body that may make you then be more impulsive, which if you're both impulsive and hungry, which is pretty probable when you're diet mindset, if you're impulsive and hungry, most likely you're now on a pathophysiological pathway to potentially binge. So there's so much about weight cycling that doesn't get spoken about a lot. And I think weight cycling is a very clear and very obvious potential risk of these medications. The other thing about these medications, I was telling Shaun, I was like, we're in a petri dish. Like we're living inside a very, we're in a reality where we're all sort of a petri dish, those of us who are providers and those of us who are patients taking these medications, because every single week I get an update. I get lots of different journals and I forward a lot of them on to Shaun and others. Because every week I get a new journal publication of a new side effect. I gave a talk for the Alliance on GLP-1s. Literally, I got off the talk and I got an email from Medscape about the effect of these medications on birth control pills and the risk of pregnancy for people taking these birth control pills. Sarcopenia, we know there's risks of blindness due to some of the effects. We don't know exactly a lot about it. We don't know how long that effect can last, but that was another Medscape article. So these medications haven't really been studied for a long time. The experiment really is happening now on all of us, and there is not enough research happening to keep up with it. But those of us who are treating patients, who have lived experience with patients, we do have to pay attention. There are increased psychiatric symptoms. We'll talk a little bit about that, the use of the reality of psychiatric hospitalizations and psychiatric emergency room visits is another thing that we'll touch base on a little bit as we go through a little more. So the medications really have impact on neurotransmitters. So that's something else. Like we're talking about all the GI effects and the other tissues, but they actually do affect neurotransmitters. So they absolutely kind of have an impact on mood. We've seen people who really feel like it boosts their mood and others who feel like they struggle more with depression and irritability. It's definitely something that, quote, health professionals want to be assessing and monitoring and then treating if it comes up. That's a quote from Amy Walters, PhD. And we talked a little bit about the psychological, and I was mentioning the psychiatric hospitalizations. So on the potential harm side, I really want to point out that the research actually has shown that for those who have prior psychiatric diagnosis, within the first 60 days of taking these medications, there's about, correct me if I'm wrong, Shaun, I think we said it was about a third of those patients with prior psychiatric hospitalizations or prior psychiatric diagnosis had to make trips to psychiatric emergency rooms. And about 13% of people with prior psychiatric diagnosis actually were hospitalized psychiatrically within 60 days. I don't think too many people are talking about that. There is also another potential harm, and it came up in the chat too, the stigma of not taking the medication. One of the participants in the chat told me that she was told that she could not actually get certain medical treatment unless she actually went on the medication. Her doctor actually tried to insist that she take the medication. So there's not just stigma from society, but actual doctors placing pressure upon patients to take these medications. And I would venture to guess or would bet that doctor did not perform informed consent or engage in informed consent with that webinar participant. So there are some potential benefits where people do report improved self-esteem or self-efficacy, some improvement in depression in some patients as well. So we're trying to give a balanced presentation, and we're trying to talk about the upside and the downside. We did want to talk a little bit about something in the field that comes up a lot, which is the concept of food addiction. And we do, Shaun and I think we both share, and he's going to comment on this too, some worries about where the field is going and the idea that these medications are a panacea for food addiction. So for those people that have binging as a part of their eating disorder behavior, it's very easy for it to be kind of lumped together as a food addiction because the people who have binging behavior do a lot of engaging behaviors that appear to show up also in other forms of addiction. It is our belief, though, that restriction is really the real driver of binge eating. And based on our clinical experience of decades of this work, we know that exposure to food and doing exposure response prevention and exposing patients to foods that they have previously binged on is actually very, very helpful to reducing binging. Certainly also just exploring all the diet mindset and black and white thinking about food, diet culture, like really, really getting into that with the patient and relieving them of that rigid thinking and doing the exposure therapy actually reduces binging. We have knowledge of that. We have lived experience of that. And we think that the fact that exposure therapy actually reduces binging really should say all it needs to say about whether it's a true actual food addiction versus some consequence of restriction or restriction mindset.
Well said. And even just thinking of the assessments of how we've defined food addiction, I know there's a lot of literature that goes back and forth with, explaining how these measures are validated. There are many things that we can capture when we are performing research, but also there are little nuances as well that do add up over time, like what Wendy mentioned is we're not seeing it in practice. We're not seeing that happen with the way that with the way that people are presenting and the steps that we're taking to help people that are coming to us with exposure to diets as well as their food environment growing up.
Absolutely. So some other points that we would really like to share that just put out there that with this food addiction concept is food is biologically necessary. We do all have different neurobiological responses to eating certain foods, and some of us may have a higher reactivity, a dopamine surge from certain foods. We're not saying that these foods and eating certain foods or binging doesn't actually cause neurobiological changes. We do acknowledge that, and there's a continuum of how we all respond to these different foods. But that does not mean that they are truly addictive. We do not see people have withdrawal or tolerance, as is the case with the true addiction. And with the diet mentality and restriction, and all the social concerns, social cultural concerns that are part of the dieting and restriction mindset, we believe that the treatment of binging involves exposure therapy to the foods and breaking through the social cultural pressure to pursue body size and shape that denies biological reality. We wanted to also talk about food noise because there's a lot of chatter out there in the world. Talking about mental chatter, that's what food noise is. There's also a lot of chatter out in the field around food noise. And wow, these medications are so great because they get rid of food noise. Isn't that absolutely fantastic? So it actually, food noise is the experience where the person's got sort of a good food, bad food mentality, and they're in a conflict between their need to eat and then the prohibition against eating. So there's this battle, within the person's brain, and we believe that is really the foundation of food noise. And these medications eliminate food noise because they eliminate hunger. So that is really the foundation to the food noise cure. And so we're very concerned about where the field is going. We're very concerned about a potential indication for food noise or binge eating disorder, which we think is very counter to the true presentation of binge eating disorder, that binging is really a derivative of restriction. Binging is tied to strong cultural pressures to defy hunger and deny hunger. So we're very concerned about this food noise talk for the GLP-1s.
For sure.
And we do really believe that all hunger matters. And Shaun and I have had a lot of conversations about this, and he works with the patients, the families, the dietitians. We want to really break that. In the field for many years, there's been talk about the hunger fullness curve. I mean, in fact, my prior treatment centers, I handed out these little cards that we made that had emotional hunger and physical fullness and all of that. And when we want to go forward and advance, we feel like it's an important thing in our field to move beyond this idea that there's some big difference between emotional and physical hunger. Emotional hunger is valid. I might start thinking about Indian food, Shaun, right? That I like Indian food. I might start thinking about Indian food about 2 o'clock. and thinking I might want that. Or I was telling you about my friend from Jamaica, and they say, oh, they get peckish, and it's sort of a psychological thing as well. So all hunger matters, whether it's physical hunger, where we're just ravenous and our stomach is growling, or whether I'm starting to think about food. There might just be more urgency when I'm ravenous versus I'm just thinking about the Indian food tonight. It's not sort of an emergency right now. I just have it in the back of my mind. But these medications really wipe out all these earlier levels of hunger where we're slightly hungry, we're getting a little hungry. There's the oftentimes when you're talking to our patients, they're not even feeling hungry until like they are ravenous. And even then they may not, right? So what do you add to that? Talk to us a little bit more, Shaun, about your experiences with it.
No, absolutely. I think of that and how and I know people that we've spoken to, Wendy, they set alarms. They set
Yeah.
alarms to make sure if, especially if as a protective factor, right? But when someone's not informed, when they don't have years of recovery behind themselves or had a solid recovery process, there's a risk there because there's those extremes again. The thing that I think of with Wendy, with what you were sharing is, and I use this illustration a lot, is in our cars nowadays, and if everybody is blessed enough and privileged enough to have a vehicle, you get the check engine light that comes on,
Yeah.
right? What is that light indicating? That light is indicating that something's going on underneath the hood. You need to stop and pull over. And so that's what we're talking about here. Even if it's like quote unquote emotional hunger, it's still, there's information to be gleaned of what's going on for us in these moments. And it doesn't necessarily mean that we can use that as a means to say, oh, well, oh, that's emotional hunger. I don't need to take care of that. That's just a bad hunger. No, that's
Yeah.
not it. Like we have here, all hunger matters. And so we
Yeah.
need to stop trying to dissect things and trying to make excuses. We need to realize that we're humans and we can have emotional and physical hunger, and that's okay.
The other thing I just want to say too, I know we could talk about these slides forever, right, Shaun, because we care so much about this. Because also with wiping out hunger, right, people are also not deriving as much pleasure from eating. When you talk to patients who are on these medications, they're like, "Yeah, I lost a lot of weight, and and yay for that, and like I don't feel hungry, I don't have food noise." And they also don't enjoy food. It's also like I could tell my, person taking it, I'm going to have Indian food tonight. You want some vegetable samosa? I want some saag paneer. And it's just like, that's not there. It's just wiped out. That's sad. That's very sad. That's not acceptable.
Yep, agreed.
So when we're working through with these patients, and again, Shaun, I remember, Shaun, the very first time you called me and you're like, hey, there's a patient in the pipeline and she's taken a GLP-1. What are we going to do? And we were like, God, how are we going to work with these patients that have eating disorders or on these GLP-1s, or they have diabetes and they have an eating disorder? And what are we going to just do? Come and say, no, go away. And we said, no, we're going to bring this in. Like, we're going to have to figure it out. We're all kind of figuring it out together, right? We're all working on it together, but we wanted to create this diagram to kind of show you how we have to work with people to help them heal. And whether they have an eating disorder and they're on a GLP-1 or not, like, this is how healing happens. There is an aspect of mechanical eating that oftentimes does have to take place. And if patients are on GLP-1s, we really have to enforce the mechanical eating because, as you were mentioning, Shaun, people that have to set timers and things of that nature to make sure that enough food is going down the hatch. And then working on the mindfulness and the intuitiveness is all a part of the whole package of eating disorder treatment that opens up, getting out of diet culture and really teaching mindful eating and teaching to honor intuition. That's all a part of honoring yourself, honoring your essence of who you are, honoring your needs. That's all a part of the healing of an eating disorder. But with GLP-1s, we have to like really be the enforcers on the mechanical eating. And what's sad to me is like the people that come to our care, thank God we can treat them and teach them these foundational principles. But I also think with sadness, the people out there that are just taking these medications are really actually getting a medication-induced eating disorder, and nobody is monitoring them and nobody is making sure they're mechanically eating enough so that they are not at risk.
That's right. And I love that how this shows that it's that interplay, right? Because this is gonna vacillate from one section to another. It's not this stage by stage process.
And Lisa, one of our therapists at Within, said she has a client on GLP-1 who is now in therapy to process her grief around not being able to enjoy food and experience the pleasure of eating with others. That's terrible. Oh,
Wow. That's
yeah,
awesome. Thanks for sharing that, Lisa. That's really
yeah.
helpful insight too. So what do we do? How do we navigate this in this GLP-1 era where we are with these new weight loss compounds coming at us? Ask questions first and foremost. Be mindful of who you're getting on your social media feed, where you're getting information from as well. But also have open and honest conversations with people. Share what's going on. Okay. Additionally, do your own literature reviews. Look at things, see what you find, see what it means to you. If you have problems or have trouble conceptualizing stuff, ask somebody. You can learn together. If that other person doesn't know, you both will find out and you'll go from there, right? The other thing too is we need to be careful of our internal biases. We need to respect what other people's bodies need and what their body's independence deserves as well. Okay. Be mindful as well of the impact of ongoing stigma for people who choose not to use the GLP-1s, even when everybody on their medical team is saying, oh, you need to do this, you need to do this. Okay. And that's where we can provide a lot of support. Like one of our colleagues mentioned in the chat, Lisa, she's providing that support for someone that is processing through some of the issues that come with the meds, but also we might see that when someone chooses not to take the meds and the fallout from that. Additionally, know your resources. Be sure that you're going to science-based resources, and we have some resources here on the right side that can help you along your way with that.
So there are some interesting areas of GLP-1s that are on the horizon for alcohol use disorder, and we're going to present. We aren't going to have time to go into a great discussion. We're going to present with you all some predicaments that we've encountered with these patients, and if we had more time, we could all go into a wonderful conversation, I think, about these predicaments. But one of them involves the use of these medications to help reduce the problems associated with an alcohol use disorder. So some early studies are promising there. There's some studies around Alzheimer's disease and neuroprotection, some improvements seen with sleep apnea. There's certainly a whole lot of information about PCOS. I know some people taking this for PCOS, and then potential cardiovascular health. So there's some expanding therapeutic horizons and future implications. It's all going to go back to informed consent, in my opinion, to figure out and assessing risk-benefit analysis to know when these medications may have a use. Because Shaun and I aren't here to be, the ones that are saying these are terrible medications never to be used. That's not the point. But we do have really strong foundations for how we think they should be used and what we should be doing if we're giving these medications. Yep. So we do have I think the next slide is the predicaments, if I'm not mistaken. So I'm just going to read these to you all. And if you guys want to reach out to Jamie, she can send this slide to you. So when we've done this talk live, we just presented the case presentations and that groups come together and like wrap their head around what to do, because what we also want to convey is that Shaun and I don't know it all. We're in the world with you together, figuring these medications out. Like I said, getting a new, Medscape article every week on potential side effects. So we're in it together. So these are just some of the predicaments that we've seen that we think are worthy of further discussion. We had a patient of a 55-year-old with a PTSD history, MBED. She had a long history of treatment Within prior to then going on a GLP-1. And the patient also had type 2 diabetes. She went on the medication, and incidentally, in this case, she actually did fairly well with the medication for a period of time. She did say, thank God I already had treatment at Within, because otherwise my whole sense of well-being would all be tied to the weight loss with these medications. And she was more joyful around the movement and things. The follow-up to the follow-up is that she later went off the medication and she went on a lower dose and she gained back a lot of weight. However, her prior treatment, her treatment for her eating disorder has sustained her, and her mood did not tank when she gained the weight back. So that was just the natural progression there. Then the next one is a 23-year-old patient with bulimia and alcohol use disorder. And she was losing weight from the medication. However, the medication also seemed to be helping her with her alcohol use disorder. That's a predicament. Wrap your head around that one. I don't know where to go with that one just yet. So I was going to be really interested to hear what people said about that. Then the other case that I know of, this was not a patient, but this is somebody in my life that I knew, of woman with no eating disorder history, but very, very picky eater that had motility issues and hypertension. The patient became very, very weak though, because guess what? Her picky eating got even worse. She was really losing weight fast, but she did start to have weakness. So she was having weakness. However, she also had improved mobility. So again, these medications are bringing with them these clinical predicaments that we want to share. And again, Jamie can share these with you if you want to have them maybe in a group practice or just have further discussions, because they're ethical and medical and legal dilemmas and predicaments like woven into all of this. And I don't think anybody has the answer on all of this. This is more time, like Shaun said, to share and exchange ideas to kind of figure out, how to approach these patients.
Cool. Well, and so to wrap it up, y'all, key takeaway, just because a patient isn't hungry doesn't mean they don't need to eat. Nutritional adequacy requires intentional planning when hunger is no longer a reliable cue, especially in individuals with eating disorders. Additionally, we know that many of the effects of these medications are still to be determined. So stay tuned. We're learning alongside with you, and we're walking alongside each other with it. And like what Wendy highlighted throughout the talk, and which is so important to the foundation of what we do, informed consent. Be sure that we are informing the people that we work with and as well as ourselves.
So we'll wrap it up with some quotes from my mom and my dad. These are wonderful quotes that have influenced me a lot. So my dad used to always say, there ain't no such thing as a free lunch. He called that tan staffel. He'd say, Wendy, there ain't no such thing as a free lunch. And then my mom used to say to me, Wendy, the road to hell is paved with good intentions. So I believe with GLP-1s, if my mom and dad were here, these things that they instilled upon me early on, like, wow, with GLP-1s, could it be more true than these 2 points? So mom and dad, hat is off to you for teaching me this. And GLP-1s, really, this is really an area where these quotes from mom and dad come into play. And I am delighted to share my mom and dad's quotes with you today and have their legacy go forward. So we do have about 13 minutes now for some Q&A. And we have Q&A cooking. Do you want to read the questions, Jamie? And then Shaun and I can go for that?
Yes, this one is
Perfect.
coming from Maria. Hello, Maria. A
Mhm.
dietitian one of my clients works with claims that tirzepatide,
Tirzepatide.
okay,
Tirzepatide.
Monjero. Good job, Jamie.
thank you, does not affect appetite as much as semaglutide and has slower weight loss effects. Is this true?
Shaun, why don't you hit that one?
Yeah, so from what we see, that is actually that is true. The thing is when you look at some of the studies, and it depends again, like when you're piecemealing them together, some of them show greater weight loss, but over time, like what you're saying, has slower weight loss effects. That's what we've seen. Specifically, though, the effect on appetite is something that has been seen with semaglutide, specifically of how it functions and how it works with the direct contact with the central nervous system. The tirzepatide, that GIP, the addition of that GIP, since it's dual, does play a role. But we find what we see now is that the single agent has a stronger effect on that end.
Very nice. This one's coming from Jordan. Recently took part in an ECHO series on the overlap of eating disorders and substance use disorders. There is growing interest in the use of these to treat substance use disorders. This seems very high risk for substitution of one addictive like brain condition such as alcohol use disorder for an eating disorder. Can you comment on general challenges of SUD plus ED management and how this could complicate things further?
Definitely. I'll take that one. Shaun, please feel free to add. So
sure.
I think that this is a very common predicament, the SUD plus the eating disorder. And you're right. If we, okay, it's helping with this. That was my predicament. We're helping with the substance abuse condition, but are we actually now inducing an eating disorder? And over the last 2 decades, I've treated many patients with co-occurring conditions. I believe firmly that the better route of treatment for people with co-occurring conditions, if you have to choose between an eating disorder program and an SUD program, to choose an eating disorder program that is well versed in SUD. Of course, like this is assuming they don't need to detox and they aren't needing to be hospitalized. Like they're appropriate for the level of care that we're talking about. But when we bring people into eating disorder programs where we have proficiency around the substance abuse, we can better manage the whole person, because the problem is when a person goes solely into SUD treatment, if there isn't very strong eating disorder knowledge, the SUD can get under control and the eating disorder is just like flaring up, which is to your point. So it's in a sense better to treat where there's strong eating disorder plus SUD, so that because the SUD programs tend to not have the eating disorder knowledge. So we work with patients that would then, with the co-occurring condition, from the mindset of we've got to get to the underlying dynamics that are driving these behaviors. They could be psychodynamics within the culture, family of origin, biopsychosocial, surroundings. They could be underlying psychiatric conditions, which is so often the case when these two conditions co-present. The high likelihood of PTSD or CPTSD that hasn't been treated, that's really the person is like self-medicating with the substance abuse or with the eating disorder. So that is one of the problems when you take a compound that just gets rid of a symptom, whether or not you've actually healed the underlying issue. We can get rid of an eating disorder behavior by putting somebody in a contained setting and making them eat and not letting them binge purge or over exercise. The eating disorder symptom is gone, but we didn't actually treat the patient in a way that it's going to generalize to what's going to happen outside of there. So when you have an SUD and an eating disorder, 9 times out of 10, you have trauma, you have depression, you might have OCD, but you have something else psychiatrically driving this forward that needs to be addressed. If you're going to put a patient on this medication for alcohol use disorder, I would argue that you be very mindful of the fact that you might be inducing an eating disorder. And that's where the mechanical eating is also going to have to come in. And somebody's going to have to be monitoring and making sure the weight loss isn't happening too quickly. And further, that the person's still able to enjoy food is like a big part of like helping somebody have well-being, overall well-being.
Also, just want to shout out Cheryl D'Amato in the chat. She's our go-to for co-occurring on the Within Health team. And so she's putting some interesting things in the chat. So thank you, Cheryl, for putting in there you go. Oh, we love you too. All right, another question from a different Cheryl. Can you talk more about B12 testing and how serum testing might not be accurate?
Absolutely. So I didn't go into great detail with that on that slide. And Cheryl, I appreciate you. Sorry, not Cheryl D'Amato. We love you, Cheryl D'Amato from Within, and Cheryl Harris. We thank you for coming in here and talking with us today. But we wanted to, so specifically with B12 testing, so everyone's on the same page there. What we look at is an MMA level and not mixed martial arts. We're not talking about that. We're talking about MMA, methylmalonic acid. It's a substance produced in the body when B12 levels are low in the blood. So measuring this MMA level in the blood can actually help determine a B12 deficiency when it's present. So I think that's what Cheryl was hitting on there, just so for clarification purposes for everyone here.
Next question is from Sarah Wilson. Hi, Sarah. If time and within scope of today's talk, can you share your insight experience regarding transgender, non-binary, and gender expansive folks with disordered eating disorders using GLP-1s to support embodiment goals? And if there are additional nutritional considerations for those on gender affirming hormone therapy and or preparing for surgical interventions?
You want to start with that one, Shaun? Because I think
Do
you
you want
might.
to take it so we hit on the
Oh,
GLP-1s and I could hit on the nutritional stuff?
okay, great.
I'm
I
happy.
think,
Yeah.
yeah, I mean, I can just say, I think this is such a really, yeah, this is a whole talk, Sarah. Thank you for
Yep.
asking it. And it's really bringing, some questions and ideas to my mind. So thank you for making me think harder. I feel like with my, with the field in general and with my own professional evolution, thank God we're at a point now where we understand that not everybody's eating disorder behavior is coming from the same driver, right? You have
Mhm.
people that are fit that are doing eating disorder behavior for a particular reason. You have people with anorexia nervosa that are doing eating disorder. And then you have folks that develop eating disorders who have issues around this embodiment that we need to be aware of so that we're not pathologizing what they're aiming for, which is this embodiment piece. And we have to help them find a balance between, yes, I'm pursuing this embodiment piece, but at the same time, am I starving myself? Am I making my relationship with food, miserable? And I think it's the same thing if they are taking a GLP-1 around this issue. It goes back to that tough but simple question of risk benefit analysis. Because, okay, this embodiment issue is really important for this person's well-being. I can accept that, I can wrap my head around that, and let's go forward with that. However, if that person has now got no enjoyment of food, or that person is developing gastroparesis and may have like a risk for abdominal obstruction, or they are at risk of weight cycling because they're not going to stay on this medication forever because it kind of sucks to not enjoy food, by the way, or whatever. So you have to actually go grapple with all these different like potential risk benefit issues. There again, you're pointing out in this patient, maybe there is an additional benefit of this medication that another person may not have because it's supporting embodiment. Okay, that's going to weigh in the favor. Okay, maybe we will consider this medication, but that doesn't mean all the potential side effects are gone. Shaun, anything else? Oh,
No, it
nutrition.
looks like
Yeah, you could take
Laurel
the
in the
second
chat was
part.
just
Yeah.
saying that. And I completely agree with you, Wendy. That's where my mind went with the question. And Sarah, it's a really great question. And I think there are so many things that, again, it's a nuance, and we need to look at all those things and what's going to be the best benefit and where that person really wants to be. As for the nutritional considerations, there's definitely a lot that we can get into with that. And I guess the biggest thing to walk away with the question right now for gender affirming hormone therapy, if someone's on that or preparing for surgical interventions, is there nutritional considerations? Absolutely. Especially if someone is having surgery, and this is something we didn't really hit on, but just the importance of adequacy when preparing for surgery, but then also with the hormone therapy, the changes that those hormones can cause metabolically, we definitely need to take that into account, and that might look like being more intentional with specific macro and micronutrient distribution in someone's diet. Doesn't mean that we would put them on a quote unquote diet. It would be, okay, how can we actually incorporate some of these foods to help support the continued metabolic changes that would be happening with all that? But great questions. Thank you, Sarah.
Excellent questions. I think we probably have time for one more. And this question is from Claire. She says, is there something you are starting to use instead of the traditional hunger fullness scale with patients?
Hmm.
That's
Well,
good.
I don't know, Shaun, do you want to start with that and then I'll follow?
So yeah, so Claire, I feel like I'm going to disappoint you, but we haven't yet. Let's say that we haven't started using something instead of. I will say that myself and the dietitian team have been utilizing many different tools, and one of the tools that we send to our clients, if we have some clients on the call with us, is they know what they get in their welcome box with us, but it's a hunger and fullness wheel. And so it's just not a specific scale that's very linear. It's something that actually incorporates many different body sensations and feeling words and somatic experiences with a client, so that we're not just focusing, specifically on the number 0 to 10. Yeah. So stay tuned for that. But we are constantly evolving with how we are providing care to make sure that we are providing the best care.
And I think even though we do use that because I think it helps open the door to mindful eating it's really teaching like awareness and working on interoceptive awareness like that we're really going for with that.
Mhm.
That's why we use the hunger fullness scale. I do think that I'll sing your praises and the team's praises. I think I think we have a very sophisticated team at Within that understands that, quote unquote, emotional hunger. That's how come we put it in quote. Emotional hunger actually matters. I think our team is really skilled and knows that. And we do educate people all along the way. We educate, because eating disorder treatment does require this educational component, and it requires that we teach people there's a new way to be with food. And it does involve this mindful eating. And with somebody on GLP-1s, that may also involve this mechanical piece of it. And they may have to be educated, like your intuition to eat, it's not going to really come with these medication, which I think kind of sucks. But so we're going to have to really weigh on the mechanical and the mindful eating, so that the hunger fullness scale is really about helping us have that conversation with patients, to have the awareness of I'm a little hungry, I'm a little bit more hungry, I'm very hungry, and that sort of thing.
Well,
I think that we
are at
got through
time.
everything.
Did you have
Yes.
one other comment, Shaun? I don't want to cut you off.
Well, I know Susan put one in, and this is such a quick answer. It's easy. She
Okay.
asked about 100 grams of protein per day. How do you address this misinformation? If you're just eating protein doesn't build muscle. Carbohydrate is what you need to get the protein mobilized. So anyway, just wanted to leave it at that.
This man can like keep going on this. Like you just fire away those nutrition. He's like, boom, boom, boom.
Shaun is in his zone.
I want to say thank you, Jamie, to you for putting together. This is your baby. The Within Summit is your baby,
Yes.
and you handle it with such care and love and wisdom. Thank you for making this possible. And to say to the audience, I want to just say thank you for being here. And also, I'm going to just do a direct thing to say we love taking care of patients at Within. If you have somebody suffering from an eating disorder or you have just a question, you want to talk with somebody from the team about a patient, like we are here, we're a part of the community and we love connecting with you. If a patient needs help, we're here to help. So call us if you have a patient on the fence. 6 to 8 weeks of our program can make a really big difference. But if you want to run a case by us, like Shaun always makes himself available. One of these GLP cases, I'm certainly available, and other members of the team. So just wanted to mention that before we wrap.
Thank you so much. Any last statements, Shaun? Are you good?
I say thank you. I just sharing in the thanks. It's just humbling to be here with you, Wendy and Jamie. Thank you guys for the invitation, and thank you for all the people that spent time with us for the past hour and a half. It's awesome.
We love it. And we love your comments. We love your feedback. As they both mentioned, we can't do this without you. So what we'll do now is we'll wrap this session and then we will reconvene at 1 o'clock and we will hear from our very own Ryan Sobis. And she's going to be talking to Dr. Michael Guyton. And we'll be talking about safer places and happier faces for our LGBTQIA+ youth. So we'll see you back at 1 o'clock. Thank you, everyone.
Thank you all.
Bye.
Bye.